Welcome everybody to our maintrac online forum. Today, Professor Pachmann is gonna talk about the therapeutic substance testing on circulating epithelial tumor cells. And I think most of you know Professor Pachmann already, but nevertheless, gonna shortly introduce her. She's our main researcher and she founded maintrac, I think, almost 20 years ago. So it's been a long time. Just some organizational stuff. Please turn off your microphone and your camera so that there is no background noise. And just to let you know, this meeting is being recorded. So yeah, we're gonna have some time to discuss your questions. There will be discussion pages that let you know that it's possible to do a discussion. And we would like to ask you to please write your questions in the chat, so it's easier for us to just do the presentation and then do the questions in the time that it's meant for it. So yes, I think that's everything from my side so far. Then you can please start, Professor Pachmann.
So thank you, Julia, for introduction. I would like a good day, good evening, everybody. I would like to present today a feature of the maintrac testing, which I think is very important for you as a treating physician, and that is the therapeutic substance testing on circulating epithelial tumor cells. As we all know, most of the carcinomas are of epithelial origin, and carcinomas can disseminate or release cancer cells into the circulation, and we call them circulating epithelial tumor cells. And they can form new, get out of the vasculation and form new tumors, the metastases. The maintrac approach is a minimally invasive procedure that allows detection of living circulating tumor cells, and it can also be called liquid biopsy. The maintrac approach allows cell counting, and the topic I will go into more detailed therapeutic substance testing, but we can also test for therapy relevant tumor cell characteristics. And finally, we can grow those cells among the circulating cells that have growth activity or growth potential into tumor spheres. And we call this approach STEMtrac. How we go ahead is we have a fluorochrome conjugated antibody against a surface property of the tumor cells, the EpCAM antigen, and thus we can detect the circulating epithelial cells among the normal blood cells. It's a highly sensitive detection procedure. We do not need any enrichment steps. It can be used for all solid epithelial tumors. It's fast and reproducible, and it's performed in a laboratory with a DIN ISO 15189 certification. Our procedure, the workflow, is shown here. So we receive the samples from you. The first thing we do is red blood cell lysis, and you can see in the third diagram down here these tiny sediment, that's the white blood cells, and among them are the tumor cells. This sediment is then stained with or labeled with a fluorochrome labeled antibody against EpCAM. The suspension is transferred into the 96 well plate, and then the special microscope scans these wells and presents us with a gallery of cells, which we can then check, and we can draw a trajectory of cell numbers over time. Here is a gallery of cells which are typical. So on the right side, That's the tumor cells staining, and what we want to see is a nice nucleus in these cells, which lacks in the gallery here on next, and so we exclude these cells, and then we can, which is very important for the cell substance testing, we can then determine the dead cells due to the red nucleus, which is possible by substance like propidium iodide entering the cells due to their permeable membrane and stains the nucleus red. So that's the dead cells. So now I would like to talk about the substance testing. The substance testing shows the response of the tumor cells or the lack of response to cytotoxic substances. And this is done for the individual patient because the same cytotoxic substance can be effective or not effective depending on the individual patient's cells. All substances can be tested in different concentrations and combinations, as well as under hypothermia. But I would like to emphasize that it's only possible for substances which are cytotoxic, either the conventional substances or even natural therapeutics. How this looks like, we expose the cells for different times to the respective substance, and you see here in the control, this cell does not die. Whereas with substance 1, there's an early response, substance 2, a little bit later response, and substance 3, intermediate. So we can expose the cells for different times to the substance, and then we can record the dying cells, individual dying cells. And I'll show you here how this is shown. And here a substance has been added, and if you look at these two cells, this cell does not die, whereas this cell continuously goes into cell death. We report the extent of cell death in percentage. So in this case, with docetaxel, 75% of the cells died, and less during, for example, doxorubicin. So it's given as a percentage of dead cells from the whole living cells. Interpretations of these numbers, if it's less than 10% effective, it's ineffective. 10 to 50%, we call it marginal efficiency, and more than 50% is effective. Where would we suggest you to use this test? It's just some scenarios, but there are more. For example, after the initial diagnosis of a primary tumor, before the therapy is initiated, we can test whether the planned substances will be effective or whether there's a high probability that they are effective. In the metastatic situation, it may be necessary before starting a new therapy if the previous therapy had not been effective, and sometimes in the case of progression of disease under treatment. Here, there is an example how the sensitivity of the cells of a patient can differ during the treatment of the patient. In this case, there was first one substance, epirubicin, and this was effective, but cell numbers came up again. Then the next substance reduced, but the sensitivity of the cells already decreased. And with the third substance, there was only a low sensitivity of the cells left. So the drug sensitivity can change during the course of disease. And this is an example of the treatment during the therapy due to the sensitivity of the cells to the drugs. So this is a patient with ovarian cancer, and she received carboplatin and paclitaxel, which is a common treatment for these tumors. But we could already see that these two drugs were not very effective, and indeed her cell numbers increased, and finally at the end of the treatment of half a year, a progression was diagnosed. The patient was then switched to therapy with the doxorubicin as tested before, and indeed her cell numbers went down and she remained in a stable disease for quite some time. So here we can discuss whether if you have any question.
Maybe you could answer some common questions that often come up. The first one being whether there's a panel of substances that can be tested?
No, usually we do only test those substances that you request us to test. We do not offer a common panel, but we have a series of substances which are very commonly used. And if you ask us, we can test these substances according to your request. We can also test natural substances and we can report whether they have cytotoxic activity or not.
Okay. And as you mentioned before, we always look at the cells after 3 hours, after 6 hours, after 9 hours. And do you also report that, or is it just being tested that way?
No, it's just being tested that way, and we report the highest efficiency of the substance during time. But what we also do, and which has not been shown here, is that we test the substances also in different concentrations. We always use 3 concentrations. The concentration which is usually given, daily dose, and a 10th concentration and a 10-fold concentration. And there should be always this concentration dependent increase in cell death. And this we can report for you if you want to. So you can vary also, especially with natural substances, your concentration given to the patient.
Okay. So I think there are no further questions, so please continue.
Okay. So I will show some case reports on therapeutic substance testing and the clinical impact of this testing. So this is a patient, 48-year-old woman, diagnosed with breast cancer, which was estrogen receptor positive, progesterone receptor positive, and HER2 new negative. She received neoadjuvant chemotherapy, as is used very frequently now. And due to the fact that in our hands, doxorubicin was more effective than epirubicin, she received 4 times doxorubicin and cyclophosphamide, and subsequently, even due to our results on docetaxel, which was more effective than paclitaxel, she received docetaxel. She had a very good clinical response. On surgery, after the end of neoadjuvant chemotherapy, she showed pathological complete response, no tumor left. She then received radiation, and cell numbers did not change during this time. And now she is on tamoxifen currently, and her cell numbers have been quite stable for a time, and now they have disappeared, and she is still in complete remission. Another patient was a 30-year-old woman diagnosed with breast cancer, again, estrogen receptor positive, progesterone receptor positive, and HER2 negative. She had first surgery And then she received adjuvant chemotherapy 4 times EC, followed by 12 times paclitaxel. This was in spite of us testing epirubicin better than doxorubicin. That's okay. But paclitaxel was less effective than docetaxel. She still, because it's the common schedule, received paclitaxel, which still was quite effective. Her cell numbers decreased, and she remained on tamoxifen, and still on tamoxifen. Her cell numbers have gone down very low, and she is still in complete remission. Do you have any questions now here?
So far, there's nothing in the chat, but maybe we saw in the first case that after the surgery, because the cell number during chemotherapy basically went down to almost 0, and then after surgery, it went up again. Is that a common thing to happen?
Yes, unfortunately, this happens quite frequently, and we have already published on this effect of surgery in the 2006. So we see it over and over again, not every time, but very frequently. And therefore, it's okay. We think that especially endocrine therapy keeps these cells that have been released into the circulation at bay. Also, some of these cells increasing may be normal epithelial cells, which then disappear during time due to the immune effect.
We also have a corresponding question in the chat now. Someone asked, I would like to understand when a patient, I don't know, had a maintrac 0 or undetected CTC, how is it possible later on an increase?
Yeah, that's also quite frequently. We see this quite frequently. It's the drugs first reach the circulating cells, which, if it's effective, are eliminated. So then it can go down to 0, but there may be cells remaining in some tissues which then are washed out over time again, which leads to an increase in epithelial or epithelial tumor suspect cells. So that's the one-time 0 does not mean that the patient is completely tumor-free. This would be only if it's repeated and repeated, no cells in the circulation.
So now there's,
yeah?
I hope that answers the question. And now there's a very long one. I would like to ask you that in that case, tamoxifen works very well, but at this point we cannot speak about a remission because it can also happen that the tumor cells accept the tamoxifen and that we should use another anti-hormone therapy. Is it not better to test again, like all 3 months to 6 months, if the tamoxifen works, or other substances too, because it can happen that tumor cells go up again?
Yes, that's correct. That's very correct. Tamoxifen does, in most cases, not really kill the cells. It silences the cells, so they remain at the same level, and they can remain over years at the same level. That's assumed to be dormant cells, which have been, for example, silenced by the tamoxifen, and there can happen any effects that we don't know, which then stimulate the circulating tumor cells again, and they can increase. If during tamoxifen treatment cell numbers increase, we would then suggest to change therapy. But the same can happen during aromatase inhibitors, because all of them do not kill the cell, but preferentially silence the cells. Is this?
I hope that answers the question. If not, please feel free to ask again. And so far there are no further questions, so I think you can continue.
Okay. So now I would like to give you some case reports of metastatic disease, which is more complicated, unfortunately. This is the case of a 70-year-old woman diagnosed with metastatic pancreatic cancer. She had palliative chemotherapy with gemcitabine and paclitaxel, which both tested very effective in our test. She had a reduction of circulating tumor cells to a very low level and a good clinical response. That's shown here before she had metastasis to the liver, before treatment, and after treatment, the metastases were almost disappeared, and she is now still in very good clinical response. Another case of a 30-year-old man diagnosed with metastatic colon cancer, which had a KRAS mutation. He received chemotherapy with FOLFIRINOX, where we showed that irinotecan, which is the IRI in the treatment plan, was effective, but not oxaliplatin, which is included also. His cell numbers remained first stable, did not increase. After surgery, there was a decrease in cell numbers, and he had at the same time a therapy with complementary substances, and he had a very good clinical response. And this is another case where we tested the gemcitabine, doxorubicin, sorry, and it was low effective, and you can also see that during treatment cell numbers increased and the patient had a relapse. She then received paclitaxel and gemcitabine. Initially, cell numbers decreased, but they re-increased, and again, we assume in this case the substances were not very effective, so it was not astonishing that she had a relapse. There were two natural substances which would have been very effective, but she did not receive this treatment. So do you have any questions?
So far, there are no questions. Maybe for better understanding, I think you once told us that sometimes the substances do not work in the metastasis because of the vascularization. Is that correct?
That's correct, but because of the lack of vascularization, because inside the metastasis, which often are very tight, the vessels are collapsed. So even if the tumor is highly vascularized on the outside, there can be collapsed vessels inside the tumor, or very frequently are, and then no substances can enter into the metastasis, and they can grow in spite of principal effectiveness of these substances.
Okay, we have one question. Wouldn't it be better to test in metastatic situation only stem cells?
That's correct. I didn't allude to the stem cells before. I will show some pictures of the stem cells, yes, but the stem cells are very resistant to most of the substances. So I'll go ahead with that on our current research. This is exactly the question. So the cells, individual cells, can grow and form spheres, which means the mother cell divides and the daughter cells are adherent, and this forms small spheres, as you can see here. So these are all spheres of containing between 30 and 100 cells. And we can also expose these spheres subsequently to different substances. And as you can see here, most substances which are very effective in individual cells, mainly that's the taxanes, are not at all effective on the spheres. We only found epirubicin being effective, but not that high, and salinomycin, which is used by one of our doctors, and curcumin being very effective on these spheres. So you can see here, even if there is the drug added to the suspension with the spheres, they do not show cell death. And I'm sorry, we do have also pictures on curcumin where you can see, and salinomycin, where you can see that the spheres disintegrate and die. So the consequence is that most tumor spheres are more resistant to the agents than the individual cells. In summary, maintrac therapeutic substance testing allows assessment of the sensitivity of the circulating epithelial tumor cells, and then individually the therapy can be chosen. What are scenarios where we would suggest to test? We need 2 times 7.5 EDTA, uncoagulated blood samples. And for example, it would be helpful before neoadjuvant chemotherapy to test whether the cells are sensitive to these drugs. Then it can be tested 3 to 6 weeks after surgery, because, as I mentioned, and as you asked, there can be cells released during surgery. Normal cells most probably will disappear, but there can be cells surviving and remaining in the circulation. These can then be tested and can be given the respective therapy to them. Then after chemotherapy or during chemotherapy, we would suggest to test 2 to 3 weeks after each chemotherapy cycle or in the middle of the chemotherapy. Often chemotherapy adjuvant consists of one part with 3 to 4 cycles, and then the second part with another substance. Then 2 to 3 weeks after completion of the therapy, we can test, we would suggest to test to see whether the therapy has been effective. And since most breast cancer and prostate cancer patients, or many, are treated with long-time hormone or other maintenance therapy, their blood sampling is possible at any time. And if cell numbers remain stable, we would suggest first testing every 3 months, then in the long term, every 6 months, and possibly every year. We can also, and think this is very important, to test after all the therapy in the therapy-free period. And we also initiate a trial now where we test the last time in hormone treatment when the patient or the doctor feels that the therapy now should be terminated. And then we look for the cells afterwards every 3 months, and we hope to be able to distinguish with those patients with increasing cell numbers, which are at the higher risk of relapse, from those who remain stable or even decrease in cell numbers during the therapy-free period, which means that they have a good chance of remaining metastasis-free. So I thank you for your attention, and I'm open for any questions now.
We do have some more questions relating to the stem cells. So there's one question. So the metastases are more resistant than the normal CTC cells. That can also be an info. We can use it to give the test substances, maybe also in glucose infusion, or we combine it with IPT, like insulin potential therapies, right?
Potentiated.
Potentiated, yes. Or maybe we can use a Trojan horse so that we have a better chance to handle it.
Yeah, that's a very good comment. And we had been asked before, possibly hypothermia can also be an adjunct to help to open the vessels inside the tumor. But this remains to be investigated. But as you mentioned, yes, I think it's very helpful if we see the circulating cells respond, and if the metastases do not respond, that we should use additional approaches.
Okay. And maybe it's worth mentioning that the sensitivity testing on the tumor spheres is still basically research, and we do not yet, at least, offer it commercially.
Yeah, we can do it on special request, but we need more data to confirm these results.
And then there's one more question. Is salomicin already registered for humans?
No, it is not. But we have also, and we are just collecting our data, that other antibiotics might be effective on the circulating tumor cells. Salinomycin is now used by one doctor, but as far as I know, he can supply people with this drug, and there is a high research activity going on in Poland to more learn about salinomycin treatment.
So if anyone has any more questions, you can also always write us an email at maintrac@laborpachmann.de, and also always call us if you have any questions. There's one more question. Maybe I can answer to a point. Is it reliable then, the tumor sphere test, or do we need to take the results with very precaution? We have to differentiate between the tumor sphere testing itself and the substance testing on tumor spheres. So maybe Professor Pachmann, if you want to elaborate a little bit.
Yeah, the sphere forming capacity is very reliable. We have been doing, like it's requested by the ESO accreditation. We have done repeated growth of from the same sample, and we got very comparable numbers of spheres. But like we previously mentioned, it's difficult to test then the substances on the cells. And it seems these tumor spheres often are very resistant to different drugs.
Maybe, I don't know if you have seen I think it was the first online forum this year. We also have the video of that on our YouTube channel. It's all about the tumor spheres and how they work and basically what we test. So maybe if you're interested, you can watch that video again. And we do have another question. There's somehow a contradiction. CTC react on medication, but stem cells hardly. So how can treating CTCs lead to a good outcome when the stem cells are not killed?
Well, not every patient has these growth active stem cells. And as I mentioned before, we can reduce or eliminate the circulating tumor cells. And then if there are no stem cells present, the patient is close to be cured, especially if there are no circulating epithelial cells which are reactivated, which unfortunately can happen, which might then drive the tumor again. But not, as mentioned before, not all patients do have stem cells present in the circulation. Okay.
So I think no one has any more questions. I would like to say thank you very much, Professor Pachmann, for doing this presentation. And thank you everybody for joining us this evening or morning. I don't know, wherever you are. And the next forum will be in October, so in 3 months' time. And we look forward to seeing you there again. And yeah, I think that's everything from my side.
Okay, goodbye.
Bye-bye.